This is a patient with a previously implanted toric IOL which rotated 90 degrees after a capsulotomy. So we have to explant the IOL and implant another one. We are going to use an Artisan Toric IOL, opening a 5.5 incision and making two paracenteses with a distance between them of 8.5 millimeters. We mark the claw location and the axis of the cylinder before starting the surgery. We protect the endothelium with viscoelastic and start moving softly the intraocular lens. In this case, as we have a capsulotomy, we have to be very careful to avoid an IOL luxation into the vitreous cavity. So we inject viscoelastic also under the optic of the IOL. The movement of the instruments into the eye must be soft and calculated to avoid any complication. As you can see here, we are pushing the IOL to the anterior chamber, and now we are going to introduce a Sinskey hook to elevate first the optic and then the periphery. In these cases, a useful maneuver is to take the Sinskey hook and surround the limits of the IOL, moving softly the iris to let the intraocular lens pass through the pupil and locate it into the anterior chamber. Once we take out the lens, we use triamcinolone acetate to look for vitreous wicking, because as you remember, this patient had a previous capsulotomy who was the cause of the rotation of the lens. We locate the vitreous wicks and we practice an anterior vitrectomy. And then we close the pupil with acetylcholine and we insert the toric Artisan IOL into the anterior chamber. So we locate the claws in the places we marked before, and we use a back-of-fix system to make it easier and less traumatic the IOL implantation into the eye. Finally, we suture with 3 10-0 nylon stitches.